I am Ramaswamy Govindan, a medical oncologist and a professor of medicine at the Washington University School of Medicine in St. Louis. I've been treating patients with lung cancer for nearly 23 years. When I began my practice back in 1998, um, we treated patients only with cytotoxic chemotherapy. And very often patients had to come in the hospital and there were no salvage therapy options. Docetaxel was coming in and paclitaxel was beginning to pick up steam. And there was no such thing as targeted therapy or immunotherapy at that time. I remember sitting in meetings designing studies for EGFR inhibitors, and somebody said it's going to be a pill. And I remember the astonishment we all had. How can a pill treat a patient with lung cancer? Now, 23 years later, we have come a long way. We still have a long way to go. But during this time, have we seen patients who have had exceptional responses, who have done amazingly well? Yes, and I can give quite a few examples in various subgroups. EGFR mutant patients. I have a wonderful 60-year-old lady who came to see me with metastatic lung cancer, bone metastasis, and she has been on afatinib now for 6.5 years or so, and has not progressed, and has done amazingly well and never had to change. And I've had patients on erlotinib. This is a surprising thing. A patient with progressive disease, the squamous cell lung cancer, there was a study of erlotinib in the population and had brain metastasis, and she had a near complete response, and now she's reaching 10 years on erlotinib. And I have patients with ALK-positive lung cancer now 9 years with metastatic disease and doing exceptionally well. I have a lady who went on one of the first patients we enrolled in the tislelizumab study, now 6.5 years, and she's in complete remission, metastatic lung cancer, doing quite well. And now and then she has a minimal progression, and then we put her on tislelizumab for 6 months to a year and then stop. And but she achieved complete response as a part of the study, and then had a slight progression here and there, doing very well, going about doing an activity. And then finally, I can think of many patients, but I'm thinking it suddenly occurs to me that there's a lady I've been taking care of, exceptionally kind, wonderful human being, who came to see me with metastatic lung cancer, with metastatic disease in the retroperitoneal region, adrenal glands, and had a fairly big tumor in the adrenal gland, relapsed following chemotherapy and radiation. We treated her retroperitoneal disease with radiation, and then the adrenal gland kept growing. And then I convinced a very reluctant surgeon to operate on this lady, and then he did that. And unfortunately, we lost the surgeon, but she's still alive 7 years later with no evidence of disease and looking very good. And she happens to have a KRAS G12C mutation, but even treated her with anything because there's no disease to look at or follow. So there are patients that they exist, and the patients, such stories are real, and these patients do exist. And the key is to really understand the disease and treat this. And I have to say, over the last 20 years, one thing has changed. I do think we now consider treating patients a little bit differently than before. In the past, if you have some progression anywhere, we change the entire thing. Now we don't do that. If you can radiate this, like stereotactic radiation for a single liver lesion or adrenal lesion, and then we keep going with systemic therapy as before, that wasn't the norm before. They would just completely, they would be taken off. The other consideration I increasingly give to is these days we do consider surgical resection if it is possible. I mean, not really some radical ones that would put patients at risk, like the adrenal metastasis resection I talked about. And I think we are open to that much more. And the third thing that has changed is that we realize how plastic these cells are. They transform. The great example is EGFR mutant lung cancer. They're transforming into small cell lung cancer. Now we repeat the biopsies, find out what mutations are present, or the histology has changed, and then we direct therapy based on that. So we have to keep those things in mind and keep doing things as long as it's reasonable and the patient's the performance status is appropriate and to the extent possible supported by evidence and science.